Hi, my name is Sachin Narayan, and I'm a first year medical student at the Stanford University School of Medicine. I'll be presenting on our project titled Does Policy Support Optimal Care of the Injured? Association between rigor of state trauma center designation criteria and proliferation of for and not for profit trauma centers. A special thank you to Dr. David A. Spain and Dr. Jeff Choi as my project advisors. Trauma center expansion has been widespread throughout the United States, with for-profit hospitals establishing centers at a higher degree than previous decades. Prior studies have found that this expansion has not addressed areas of higher population density or injury burden. Trauma center designation standards fall under state jurisdiction and are quite variable, meaning that certain states are significantly easier to establish centers in than others. Furthermore, high activation fees make lower-level for-profit trauma centers a potentially lucrative business model. These observations fueled our study, where we aim to evaluate the correlation between the rigor of state trauma center designation criteria and trauma center proliferation rates over the past decade. We hypothesized that less stringent state criteria would correlate with proliferation of for-profit trauma centers, but not with not-for-profit trauma centers. Our study method split into two stages. One, quantifying the rigor of state trauma center designation criteria, and two, trauma center proliferation analysis. The former was conducted by manual comparison of each state's designation policies to the American College of Surgeons Committee on Trauma's mandatory criteria, listed in the 6th edition of their Resources for Optimal Care document. The latter was conducted by comparing the Trauma Information Exchange Program's list of trauma centers in 2013 to those in 2019, noting the change in for and not-for-profit numbers by each state. Correlations between these two stages of the study were calculated by Kendall's and Spearman's rank statistical tests with an alpha of 0.05. Our results indicate a highly variable rigor of state designation criteria, as shown in Figure 1. Figure 2 demonstrates each state's share of for-profit trauma center proliferation from 2013 to 2019, with the notable states of Texas, Florida, Utah, Tennessee, and Oklahoma comprising the largest percentages. Figure 3 shows similar data, but for not-for-profit trauma center proliferation, with states such as Michigan, South Dakota, Kansas, and Montana making up the most significant portions. It is particularly interesting to note the states Florida, Tennessee, and Oklahoma. They have some of the most significant contributions to for-profit proliferation, and they rank as some of the states with the least stringent trauma center designation criteria. The Spearman's rank correlation results are depicted in tables 1 and 2, for and not-for-profit facilities, respectively. Our analysis found that the only statistically significant relationships are between for-profit trauma center proliferation and state criteria rigor. Note that the negative correlation coefficients in Table 1 show that the higher proliferation rates equated to less rigorous criteria. This leads to our key takeaways, where we found that lower-level trauma centers, aka levels 3 and 4, comprised a 77% majority of newly established centers nationwide. Furthermore, the average concordance of level 4 trauma center criteria across states was significantly lower than that of higher level trauma centers, aka level 1 and 2. Together, these two findings combined demonstrate that trauma center expansion occurs more frequently for the designation levels with less stringent criteria. Most importantly though, both our Spearman's and Kendall's rank correlation tests showed us that less rigorous trauma center designation criteria significantly correlated with both our measures of for-profit trauma center proliferation. One, as a share of all new for-profit trauma centers nationwide, and two, as a share of all new trauma centers in that particular state. No significant correlations were found for not-for-profit trauma centers, suggesting that the phenomenon observed is specific to for-profit subgroup. Our study design did have its limitations, the foremost being that we only compared ACSCOT's 77 Type 1 criteria and not their 264 Type 2 criteria, which are desired but not immediately mandatory in the verification process. In subsequent studies, we hope to see if there are any further differences in terms of patient outcomes, injury burden addressed, volume, etc., between for and not-for-profit trauma centers. Better understanding the cost and potential return on investment of establishing for-profit trauma centers would also be helpful. Ultimately, we hope that this study can shed more light on the recent rates of trauma center proliferation and encourage national policies that ensure future trauma center establishment practices prioritize patient outcomes. Thank you so much for your time.